Thank you, thank you. Thank you very much. It's so great to be here. When you guys scan that QR code and put in your stuff about Texas, it's awesome, right? Very awesome. That's the only thing to answer, except it's hot, and we recognize it is very hot. For those of us that live here, we also believe it to be very hot, okay? It's not fun. But yet we stay here because we love this place. All right, so we're going to be talking about surgical treatments in epilepsy. These are going to be our goals today, okay? Number one, I want to highlight that there are multiple types of epilepsy surgery that you could consider for the treatment of seizures with LGS. Then I want to talk about some of the non-seizure outcomes. So, seizure freedom, super important, but let's be realistic. Seizure freedom does not happen for everybody. So we want to look at seizure reduction and what does seizure reduction do for other outcomes such as cognitive and developmental outcome, quality of life, et cetera. And then finally, throughout, I'll kind of discuss some of the patient characteristics that may impact your likelihood of benefiting the most from epilepsy surgery. So, is surgery an option for LGS? So, I posted this on my Twitter account, and if you're not following me, it's at the Notorious EEG, so please do jump on. I posted this because I was in clinic, and I saw a kid who I did a Corpus callosotomy from. This kid had suffered from seizures for like 15, 16 years, hundreds of seizures a day, and had been through I don't know how many medicines, 9, 10 meds, keto diet, VNS, everything. I said, listen, we don't have much left, let's just do it. Let's do the Corpus callosotomy. I think it has a great chance of helping. I think you need to do it. When we did it, she came back, this was 6 weeks later when I saw her, seizure-free from everything. I had the conversation of I'm trying to prevent you from falling and hurting yourself, but sometimes people become seizure-free. She was seizure-free from everything, and that feeling is like unbelievable, all right? For me, for her family, and so, I posted this, and then somebody followed it up with, thanks so much. I didn't even know surgery was an option for LGS. Like, well, then we have something we need to talk about. Then I posted a survey shortly thereafter and asked that very question. I said, a statement, surgery can be beneficial for people with LGS. And 80% of people said true. Unfortunately, 20% of people said false. So that means I got 20% of people I need to get to because they don't understand that absolutely yes, surgery can be beneficial and is an option for the treatment of LGS. So this is what I want you to know, is that epilepsy surgery is not a last resort. Do not treat it as a last resort. Every person is a candidate for epilepsy surgery. It's just some people are better candidates than others. And that's where we have to have that conversation and try to figure out where you fit. And so why do we consider epilepsy surgery? First and foremost, seizure control. Seizure control does not equal seizure freedom. I want to make that point here because a lot of you will see docs and you might ask about epilepsy surgery or you never heard about epilepsy surgery. And the reason you never heard about it is because people think of epilepsy surgery only in the terms of seizure freedom. And seizure freedom is not always what we need to achieve. Sometimes we need to achieve significant seizure reduction. That's what you're doing with the ninth medicine, isn't it? So why wouldn't we think about that with surgery? When you think about medicines, when a person is newly diagnosed with epilepsy, the likelihood the first medicine will make them seizure-free is about 50% on average. If they fail that medicine to the maximum dose, the likelihood they're going to become seizure-free with medicine number 2 is about 12%. If they fail that medicine, the likelihood the third medicine is going to make them seizure-free is about 4.5%. And you can see the trend. Each time, it becomes lower and lower and lower. So your likelihood of becoming seizure-free in that scenario is already not great. Your likelihood of getting 50% reduction is, on average, 50% in most studies. You'll see it's lower in many of them. And so that's why you need to have all the options on the table. What else do I have to me? After you failed 2 medicines, what else can I do? And then compare all those options. And that could be VNS, that could be the neuromodulation we're going to talk about, other epilepsy surgeries that I'll talk about, ketogenic diet, et cetera. I put down here a little something from our Pediatric Epilepsy Research Consortium group. We looked at the palliative epilepsy surgeries in our group. We had 308 kids at the time had epilepsy surgery, of which 100 of them were palliative. So these are procedures that we knew going in were not intended to result in seizure freedom. What we found were these kids were older, not surprising because they had been, put off for a while. They had failed many more medicines. They waited at least 2 or more years longer than a kid who was going for a curative surgery, even though they too were candidates. But more importantly is the outcome. 70% of the people that got palliative epilepsy surgeries had at least a 50% or greater reduction in seizures. That is much, much better than your likelihood of getting 50% seizure reduction oftentimes with another medication. Obviously, every kid's different, every seizure type is different, the situation is different, but as a whole, that's the stat. I'm going to give this to you here just to look at because I want you to use it when we're thinking about epilepsy surgery as a potential option. These are many of the medicines that have been approved over the years for Lennox-Gastaut. I have left off, I have not updated this yet, so I don't have Fintepla on here at this time. But what you can see is you look at the 50% reduction, right? On average, you're seeing people with 30% of them will get 50% reduction. Clobazam is the outlier with 77%, but compare that to the placebo group that had 32% of 50% reduction. So really there's about a 45% rate there. And then you look at seizure freedom, and you see the highest number on there is 25% of people experiencing seizure freedom. Those are people who are experiencing drop attacks in that particular study. So that's not seizure freedom from all seizures. That's just for drop attacks. So kind of keep those numbers in mind as we go through some of the surgical numbers, just so you understand the comparison. Now, a second reason that you might consider epilepsy surgery, and that's for cognitive and developmental outcome. We know that seizures adversely impact cognitive outcome. We know that drug-resistant epilepsy leads to changes and disruptions in functional networks that further impact that. We know that the earlier the onset and the more seizures you're suffering, especially in those first few years of life that are so important to neurodevelopment, the worse the outcome can be. And we know that surgical therapy, again as a whole, I'm not talking about just LGS, but surgery therapy as a whole can improve IQ. But many of the results may not be seen for years, and that's a really important fact there because a lot of the studies that talk about IQ in epilepsy surgery and after epilepsy surgery are short studies, so they're only 2 years or a couple years after it. That may not be long enough. As I explain to people, you know, they come and see them as a 10-year-old. Well, it took you 10 years to get here, so don't expect in 1 year all of a sudden we've changed so much after the surgery has completed. It's going to take time. Also, a lot of the problems, especially when you're dealing with a condition such as LGS, is that, as many of you probably know, the cognitive and developmental scales we have available to assess your level sometimes are not good enough to assess the level. Many people suffer from a floor effect, so they take the test and they're at the bottom of the test or they don't score on the scale. Well, then when we test you again, if you haven't made it on the scale, we're not going to really see any measurable change because the scale was not good enough to measure this particular group. And then, of course, epilepsy is more than just seizures, right? You all know this. There are lifelong consequences to uncontrolled epilepsy: reduced quality of life, psychosocial dysfunction, injury, especially with like drop attacks, premature death secondary to SUDEP. There are significant impacts for the caregiver, right? High rates of depression and anxiety. There are high rates of concerns about impact on the siblings. There's an impact on employment. There's a significant financial burden. So when you're thinking about what are you going to do to control seizures, you're thinking about more than just controlling seizures. What else can you get out of this? Now, fun fact, if you scan this QR code that's buried up there, you're going to get rickrolled. So I don't know if you all know what rickrolling is, but if you scan that, it's going to take you to a rickroll video. So what is the goal of epilepsy surgery? This is what you need to think about when you're going to talk to your doctor. You need to think about what are you trying to achieve with epilepsy surgery. Is it seizure control? And if it's seizure control, what type of seizure are you trying to control and how much are you looking to control it? Maybe you're just trying to improve the quality of life. Maybe you want to reduce or prevent injuries, or you want to reduce medications. These are all things to think about when you're considering how helpful will epilepsy surgery be for me. I'm going to talk about a couple. I got basic epilepsy surgery definitions for you to consider. Resective surgery is a surgery in which we either remove or we ablate, burn with a laser, for example, a portion of the brain which we have identified as the onset area of the seizures. These procedures are generally intended to cure the epilepsy, but in some cases we may use it to be palliative. These may be cases where one area of the brain seems to cause the overwhelming majority of the seizures, so we want to remove that to reduce those seizures. Corpus callosotomy is a disconnective procedure. So you'll hear people talk about disconnective procedures. This is where we divide the bundle of fibers that connect the left and the right hemisphere together. This procedure is generally intended to be palliative, not intended to reduce or make you seizure-free. However, in some cases, it does. Neuromodulation, I'm going to leave to Dr. Porter to talk about, but that's stimulating parts of the brain to basically alter the electrical activity to control seizures. And then finally, some people use combinations of these to get the best outcomes. So let's first start by talking about what would suggest that you might be able to undergo a curative procedure. And this is ever so important in the early years of life when you can get that cure before you have the significant impact of years and years of seizures, right? So certain things that would characterize a person as a potentially very good surgical candidate for a cure would be if their EEG has very asymmetric or asynchronous findings. So one hemisphere seems to have the majority of the abnormalities. Now, in very young children, it's been shown that even that may not be necessary, because a lot of very young children who have one side of the hemisphere, for instance, is very malformed, may have very diffuse and abnormal EEGs, but as long as there's just one part that's causing that problem, they can still very much benefit. Seizure characteristics are important. So if the child has fairly persistent focality to their seizures, so yeah, they have tonic seizures, and yeah, their arms come out, but it's always the left arm that's primarily, out, or, it's always a focal clonic seizure that's predominantly one side, or other signs like that. These are people who are likely to very much benefit. And then, of course, the imaging findings are very important. I show here on the a slide basically a hemispheric malformation. You see that one huge malformed hemisphere. And that hemisphere is basically assaulting that child from the day they're born with seizure after seizure after seizure. And if that hemisphere got out of there and you got rid of it, and the healthy hemisphere was allowed to do what it's able to do, their outcome is likely to be significantly better. So let me go through just a couple studies, and it's a couple studies because there's only a couple studies. There's not a lot of studies where people put a lot of info out there about LGS specifically in surgery. This study was a retrospective study, 27 patients, all less than 18 years of age, that underwent resective surgeries. So these are people, and you can see there by what their etiologies were. So they had focal cortical dysplasia, that's a focal malformation of the brain. They had focal encephalomalacia, or an area of scarring, or they had maybe a remote stroke, but 4 of them were non-lesional. 4 of them had completely normal MRIs. They underwent a variety of different surgeries, either removing one section, removing a hemisphere, or removing several sections. But look at the outcome. 60% of the patients were seizure-free. 15% of them had greater than 90% seizure reduction. So that's 75% of the patients in this trial had 90% or greater seizure reduction. And almost 30% of them stopped all of their medications after it was over. Now, importantly, 20% of them experienced no change. Didn't help them one bit. The ones that had any developmental improvement tended to be the ones that had 90% or greater seizure reduction. So this is an important thing, and this is not applied to everyone with LGS. Absolutely does not. This applies to people who have LGS secondary to a focal abnormality in their brain. That could be a hemimegalencephaly, so one large malformed hemisphere, a cortical dysplasia, things of that nature, okay? Now, I bring this one up because this study was a nice study that kind of looked at, well, what if you did surgery versus what if you did medicine? So here we have 107 patients with LGS, all they all underwent surgery evaluation. And so what happens with a surgery evaluation, just like it would happen if you came to see us in clinic, we're going to look and try to decide, are you a good candidate or are you not a good candidate? Ultimately, it should be 63, I believe, ultimately underwent surgery. That was either a corpus callosotomy alone, or some underwent a corpus callosotomy plus a resection of an area of the brain. And then there was a portion of people who were not good surgery candidates, so they stayed on medicines. And what you see is the seizure-free rates were 70% at 1 year, 60% remained seizure-free at 3 years, 55% remained seizure-free at 5 years after these surgeries. But the ones who were on medicine, that rate of seizure freedom was 4%, 0%, and 0%. So again, this doesn't apply to every single person with LGS, but that means there's a population of people that have a diagnosis of LGS that could very much benefit, that would not probably benefit by continued meds. Looking at other outcomes, and again, testing is limited here because the tests are not perfect to measure IQ in some populations, but IQ improved in 67% of those that underwent surgery versus only 4% that continued medicines. Importantly, IQ worsened for 12% after surgery versus 43% on meds. Quality of life improved more on surgery versus meds, and quality of life was less likely to worsen with surgery versus meds. So again, in an appropriately selected population, a very good outcome. And the seizure freedom is sustainable. So this is that same group. They looked at their patients down the road. Again, this is 6 years on average post-op, and nearly 50% or 50% of the patients continued to experience seizure freedom, of which I just highlight that 40% of them had normal MRI. So these weren't even lesional cases, but these were cases where after an extensive surgical workup, they were able to identify an area of the brain that was causing the problem. So now let's talk about a couple of the different surgeries one might undergo. One is corpus callosotomy. Corpus callosotomy, again, is a palliative procedure to disconnect the right and left hemisphere from each other. It is intended primarily, often when we talk about it, to reduce drop attacks, so atonic and tonic seizures most commonly, but also generalized tonic-clonic or what we call grand mal type seizures. There's 3 types of corpus callosotomies we may talk about with you. One is the anterior 2/3 procedure, where we disconnect the anterior 2/3 up to the motor cortex. The next is the posterior 1/3. Obviously, the back part is disconnected. We leave the anterior intact. The reason people have started to talk about that is because there is some evidence that maybe behavioral changes after a disconnection are a little better after a posterior. And then there's a complete callosotomy where we disconnect the entire thing. Complications of callosotomies include, most importantly, disconnection syndrome. Disconnection syndrome is one where you can have some amount of weakness on one side. You might have some difficulty speaking. You may have some difficulty with left-right coordination and transfer. In a lot of cases where we're talking about callosotomies, we're already talking about, kind of diffuse abnormalities where maybe weakness or speech delays are even already present. So you have to kind of weigh that risk with what the current state is. The other things I list there are common kind of neurosurgical risk in general. So infarct, hematomas, hydrocephalus. So how effective is it? So corpus callosotomy, this is a study of complete callosotomy. 76 patients underwent it. As you see, 50% of the patients had a 90% reduction, or sorry, a 50% reduction was present in 90% of the patients, whereas 68%, nearly 70%, had a greater than 90% reduction in their seizures. And importantly, almost 10% were seizure-free, which was not the original intent of the procedure. In this particular study, they felt atonic. They reported atonic to be best controlled, atypical absence next, and then tonic-clonic. Interestingly, one of the things that people have talked about with corpus callosotomy is that sometimes it unmasks the ability to do something else. So you've got this EEG that's very abnormal with lots of abnormalities in both hemispheres. You don't seem like a good candidate to resect one area. You divide the corpus callosum in half. You disconnect that activity. The healthy hemisphere, if there is a healthy hemisphere, starts to look better, and the one that's actually causing all the problems continues to look like a problem, and then those people might be able to undergo a resective surgery to remove the area in the hemisphere that originally started this all. The anterior corpus callosotomy, anterior 2/3, this is a study of about 60 patients who had that procedure. And here they reported 66% of the patients had either a grade 2 or 3 outcome. So grade 2 to them was defined as seizure freedom, but still on medication, so that was about 20%. Grade 3 was described as those with more than 50% of reduction, so that was about 50%. And in this particular study, tonic-clonic was reported best, followed by tonic and atonic, as we typically see. And then I'm sure yesterday, I didn't get a chance to see Dr. Lamb's presentation, but I'm sure she talked about her meta-analysis of corpus callosotomy. This is basically where she's pooled numerous studies about corpus callosotomy and looked at outcomes. And when you look across multiple sites, multiple studies, 68% of people at 2 years had a meaningful seizure reduction, which was characterized by at least 50%. In this particular case, she did not, I don't believe she specified which seizure types overall. Also looked at whether other outcomes were reported. In this case, a very small number of the studies did report quality of life and IQ, and basically about half showed at least an improvement in one of those domains. Importantly, it's always important to look at the other side. Does anyone decline? And declines are seen in smaller numbers, so 2 of 23 or 1 in 23 in the studies that produced those outcomes. Most importantly is the final line. When you ask the parents that underwent a corpus callosotomy what they thought about a corpus callosotomy, 90% of them said they were very satisfied that they went through the procedure. And I hear this a lot, you know, when I talk to people who, again, have failed 9 and 10 medications. They're like, why didn't we think about doing this a lot earlier? So let's talk about how it compares to a couple other treatments that you might be considering. And again, this is all patient-specific, but in this case, we're looking at larger kind of meta-analysis comparing these two different approaches. So in this first is a comparison of VNS to callosotomy, specifically for atonic-type seizures in this study. If you wanted to achieve a 50% reduction in atonic seizures, corpus callosotomy was superior to the VNS, 80% versus 54%. If you wanted a 75% or greater reduction, corpus callosotomy remained very superior, 70% versus 26%, again comparing to VNS. And there's a comparison to the ketogenic diet. In this particular study, the corpus callosotomy was more effective at achieving 50 and 75% reduction compared to the diet. Again, atonic seizures most notably were those that were controlled. How does a corpus callosotomy get done? There's several approaches. That's one of the great things about epilepsy surgery. Again, as you're going to hear in just a minute, we're getting newer and newer techniques that become less and less invasive, less and less scary, hopefully less and less adverse effects that make this something that's opened to more people, more palatable to more people. So laser interstitial thermal therapy is basically laser ablation, right? So what you do with that is you take a laser and you insert the laser fiber so that you can ablate the corpus callosum. As you can see, the corpus callosum is a curved structure, and a laser is a straight object. And so it requires multiple burr holes to insert the laser to make that curve. There have been a couple studies of laser interstitial thermal therapy. These have mostly involved adult populations, but as you can see, they have pretty good outcomes, 60% with 80% seizure reduction, about 1 in 5 seizure-free. This other study, which again was not LGS specific, but was adults with generalized epilepsy, 40% of them were seizure-free from their seizures. The other two approaches are the traditional open craniotomy. So an open craniotomy is where you remove the skull from the front to expose the brain and then divide the corpus callosum from there. This is obviously a bigger procedure. It sometimes is inadequately visualized for the whole corpus callosum in some cases. The recovery is going to be a little bit longer because it's a bigger procedure. And then some people are using an endoscopic or a what we call a mini craniotomy. This is done by about a 1-inch incision at the top of the skull. They then either use the endoscope with the camera and the knife to go in and cut back to forth. And that procedure is starting to be used a little more frequently. The outcomes are to be determined here. We're going to present at the American Epilepsy Society, hopefully later this year, some data on this. As part of the Pediatric Epilepsy Research Consortium, we pooled all corpus callosotomies done across 24 sites in the US. And basically what we show is that the open craniotomy approach is the most successful. In that it had about 80% of patients with 50% or greater seizure reduction. However, the endoscopic approach was right behind it at about 70-some-odd%, and then laser interstitial therapy was right behind that at 60-some-odd%. Then if you look at hospitalization time, open craniotomies are the longest, laser is the shortest. If you look at complications, open has more compared to laser and endoscopic. So there's pros and cons to each one, and you have to just compare that and decide which one's the right one for you. So here's just a quick summary of those different types of combinations and the things one might think about when they're considering these different surgical approaches. So as we come to an end here, I hope what you have gotten first and foremost is that epilepsy surgery is indeed a viable treatment option for LGS and should absolutely not be considered as the last resort. There are certain features of a patient that makes surgical therapy very high on the list. Asymmetric findings, single unilateral lesions on their MRI, persistently focal seizure semiology. Palliative procedures can result not only in significant seizure reduction, but they can offer seizure reduction that in many cases may be superior to the other things you might be considering, like your 8th or 9th medication. Surgical techniques continue to evolve, and they continue to increase the candidacy of more and more people who may benefit. And the epilepsy surgery goal should be very clear with your doctor before you pursue epilepsy surgery. Are you pursuing seizure freedom, seizure control, quality of life, reduction of medicines, reduction of injury, etc.? I will also say that, as I put there at the end, that surgical decisions are based on surgical experience. So it all depends on how active and how frequently the people you work with do epilepsy surgery, because it's a complicated process. So, the one team may tell you you're not a candidate, or another team who does lots and lots of surgery may think very differently of your candidacy. And I think that the more that we advance our evaluations and look harder for that source of seizures, the better those outcomes are going to be. But that's strictly my opinion and not supported by any facts. So with that, I will stop and happy to take questions.
Great. Just put your hands up if you have any questions, and I'll just kick us off here with one question from our home audience. Is there a surgery that is good for multifocal seizures?
Well, so yes, and that could be surgery or surgeries. So multifocal depends on where the multifocal is, right? So if multifocal means I've got multiple places in one hemisphere that's causing the problem, you may very much benefit from a hemispherectomy. If multifocal means I've got a spot in the left side and I got a spot in the right side, and those are the two spots causing my problem, that person's not going to likely benefit from take out a little bit of the left and take out a little bit of the right. We don't generally operate on both sides of the brain that way. However, that person might benefit from, let's take out the primary biggest seizure cause on the left, and on the right we do something differently. Maybe we use an RNS that Dr. Porter is going to talk about on that area of the right side that's causing the problem, so we can still treat both sides. Also, again, she'll be covering this later, but DBS or RNS to a central location like the thalamus may be something that helps treat something that's more diffuse. So there are definitely options for multifocal.
Perfect. I think we have a question over here.
Yes, hello. I'm wondering if there is a more beneficial age. I didn't notice anything in there as far as age groups. My daughter wasn't diagnosed at 50. She had seizures her whole life, but was not diagnosed with LGS until she was 15. She's now 17 and a half. Is there a good candidate age group in there?
So that's, I guess, a couple point question. So it depends on what we're looking at. So if we're looking at cognitive and developmental outcome, just in epilepsy surgery in general, the sooner you do epilepsy surgery and get control, the better cognitive and developmental outcome is going to be. So the longer you wait, there's adverse impact to that. So that's one thing. As far as safety of doing surgery, people less often do surgery in those less than 3 because of some perceived safety issues with such small children. But it is, in fact, safe and can be done much earlier. And things like those hemispheric abnormalities I showed, that's the time to do that. Like waiting till later is not a good idea, even though there are some risks to that, to do it later. Several of those studies that were specific to LGS did note that the shorter duration of epilepsy before the surgery seem to be related or a trend towards more likelihood to achieve seizure freedom, which is not surprising. I mean, the longer that the brain has experienced seizure after seizure after seizure, maybe the less likely it's going to become seizure free. So if you can stop it soon, the better.
Great. Right there.
My question is regarding the CC surgery.
Mm-hmm.
Our daughter she's 5, she has a VNS. We are seeing some improvement from that. But her seizures start from all over within. And I was listening, and I might have missed, but is the CC procedure only for when you can pinpoint an area or is if she has them from deep within and from all over, is
Right.
CC a possibility? Do we need to talk to our doctor about it?
So the corpus callosotomy is more likely going to benefit, or it's used more often for that person who has kind of diffuse onset.
So it would be a good conversation.
For sure, and what it may unveil in some patients is, everything looks bad on the EEG, and you can't find where the problem is coming from, and then you do a callosotomy, and it turns out there is a focal generator that just was buried amongst all this badness, and when you disconnect it, you start to find that abnormality, and then might be able to undergo a different surgery after that.
Okay, great. Thank you.
You're welcome.
Hi. So my question kind of tags along with this. So should our epileptologist be telling us where the seizures are generating? I'm not sure I've ever heard from him.
Well, they should if they know, but they might not know. So a lot of times with LGS, we don't know that answer, right? This is a diffuse epileptogenic network, right? I mean, one of the parts of the definition of LGS is to have this EEG with generalized slow spike waves. So that means abnormality everywhere. Now, if they look at, sometimes we look at generalized spike wave, or I see a kid, that's in my EMU, and they've got LGS, but I'm like, yes, they have tonic seizures, but every tonic seizure is very asymmetric. One arm is always more involved than the other arm. Or when I look at that EEG, yeah, it's generalized, but the amplitude of these waveforms is so much higher on this side than it is on the other side, or the one on the right always precedes the one on the left by just a few seconds. So yeah, it's the pattern, but it's showing me some hints that there's actually something that is the start of this that's causing all the problem. So yes, if they know that, but don't expect always to know that.
Great, right there in the back.
Thanks for that talk,
Over on the
Dr.
right,
Perry.
yeah.
Thanks for that talk, Dr. Perry. So I wanted to just highlight some points from Dr. Perry for the concept of age and time. We've been kind of alluding to that a little bit, which is the earlier the better if you are having seizures all the time, right? Because seizures is really taking over your brain so that your brain can't do the things that it really wants to do, like interact with family, learn about the world, and it's really holding the brain back, right? So that's why, in epilepsy and epilepsy surgery, we say the sooner the better, which means that the sooner that you have that chance of trying to reduce seizures or, get rid of the bad effects of the seizures continuing to hold you back all the time, that's why time matters, right? And then thinking about medicines versus surgery is that if you try another medicine, right, the second, the third, the fourth, the fifth, you may actually see a honeymoon period where you're like, hey, it's a little bit better. It's okay. Let's just wait, like some weeks, some months and see, and then maybe we can try again. But if you're continuing to seize, then that's still the time that it's really having negative effects on a developing brain, especially when you're a child and you're learning and kids want to learn and grow. So that's the concept of time. And then the surgery below age 3, it is a little bit more technically challenging in terms of needing a really big team to take care of a child that's quite small, right? So there's just not that much blood volume in a baby or a younger child, and that's actually when the experience of a big team, not just the surgeon, right? It's not just about the surgery, it's the anesthesiologist, it's the ICU doctors, it's the pediatrician to make sure that the planning for a surgery and somebody who's smaller in size is careful and very meticulous. So that's when you trust your spidey sense as parents and families, where you're like, am I comfortable here? Is this the right place? And do I know these people are going to take care of my loved one in the way that they've done it before, and they can tell you that.
And the only thing I will add to Dr. Lamb's great comments is for the adult folks out there, it's never too late to achieve seizure control. This is not just a pediatric need. It is never too late to get control of seizures.
Agreed. Right here up front, and then we have one from our virtual audience.
Good morning, and thank you for all the great information. You just answered my second question about age limits, so that's done. I have a question about insurance. Do all or most insurance cover this procedure?
Absolutely.
Wonderful.
Yes.
Thank you.
Great. So our at-home question is, since my son's corpus callosotomy, his seizures have dropped from 200 a month to 1 or 2. However, he has regressed dramatically in mobility, speech, developed an unsafe swallow, and a stammer. Could this be due to the surgery?
So, I mean, those are adverse effects that we have to consider before going in. Sometimes oftentimes, it's really hard to predict exactly, and that's the case with a lot of epilepsy surgeries, is that, prediction is not absolute. And that's a big step to take to do an epilepsy surgery, so I understand people, hesitance to think about that. So certainly we see those things. A lot of that deals with, what was your pre-op status, right? So if your pre-op status was pretty high functioning, then obviously the differences, if you have an adverse effect, are much easier to recognize. But it can happen throughout, and it takes, for some months. I've had some patients that have had some adverse outcomes. For example, that, we think that a lot of times these things, give us a few weeks, few months, we should see improvement. We haven't, but still saw improvement, a year later. So, those things come. So, keep working on it for sure. I'll say that.
Right. Yeah. I mean, we have families here, a little Macy here who's 6, who just had the surgery, 5 months or so ago, and is running around here and doing really well. And then Charles Wagner, who was our keynote speaker, Iron Man, his son had surgery, and he's had some deficits, but he's coming along, major improvement in seizures. And then, of course, we've got, Spencer, who I think had it a bit ago and is still really struggling. So really looking at the odds and the numbers that you've given us. And I know Dr. Perry's really leading that research in a lot of ways so that we can have better ways to understand what the likelihood of success is and complications. So thank you, Dr. Perry. I think we have another question back there. Yep.
Hi. So one of the concerns that I've always had with the corpus callosotomy is, given that it's more palliative, and if you don't know where the seizures are coming from and it's diffuse, I had heard that even by doing the CC, that the brain could rewire itself to then start having seizures, in other areas, or so that's just one concern that I had.
Yeah.
Is that something?
So that's a conversation you have to have about, first of all, what is your goal of the surgery, right? So yes, it is generally considered a palliative surgery. Like I don't do a corpus callosotomy for anybody and say, you're going to come out seizure-free and that's why I'm doing it, because that's not what's happening. We generally have a very diffuse abnormality. We're trying to palliate something. Is that a certain type of seizure? So if it's a tonic, an atonic, or a tonic-clonic seizure, let's say there's a really high likelihood that we're going to have a significant reduction of seizures, as I showed in those studies. Might you still have other places that cause seizures, and may you still have some ongoing seizures? Yes. But will that seizure, result in a fall and an injury? Our hope is no. That's the reason why we're doing the procedure. Our hope is that we reduce it so that you can have the better outcomes from a developmental and cognitive standpoint. So I think that what you mentioned is one of the reasons why, when you look at these patients that have these palliative procedures, they've tried 9 and 10 medications because they put it all the way at the end. But then they did it, and then 90% of them are very satisfied that they did it, and they had significant reduction. So why didn't they do it way back here? It's because that kind of conversation is had. Well, we'll disconnect it, but you're still going to have seizures. Well, okay, but I mean, if I said I'm going to give you your 9th medicine and you're still going to have seizures, that's what's going to happen, right? So let's talk about the risk and benefits and whether it makes sense for you, your child, your adult, or not.
Great. And one last question straight ahead.
Yeah, my son has now developed mesial temporal sclerosis several years ago anyway. And at that time when we asked his epileptologist about surgical approaches for that, he said it's a really difficult area to target. Is there anything new that's come out in terms of targeting the mesial temporal
So the mesial
sclerosis?
temporal lobe is hard to target? Is
Where
what
his
they
lesion
felt?
was, they said would be hard to target.
I guess it depends on where in the mesial temporal lobe it is, and Dr. Lamb's the neurosurgeon, can let us know how difficult it is to target, but I would suggest it might be one of the easiest places to target. That's a chip shot for the neurosurgeon.
Great. I do just have one final question.
It's doable. It is very doable with proper planning. But yeah, we don't want to say chip shot, but yes, it is a thumbs up.
She's not going to say
pick.
it publicly. I'm in the operating room with them. I know what they say.
One last question, because this is so important. My son is 42 and on 4 anti-seizure medicines. Could a corpus callosotomy even be a possibility, and would it be beneficial to have an MRI?
So 100% absolutely could it be a possibility, right? Several of those studies I showed on laser were in adults only. So definitely it can be done. I think epilepsy surgery is obviously done in adults. Palliative kinds of things start to be thought less of and less of as older people get. And that's why I made the comment that it's never too late to get seizure control, because I often worry when I send my children I've cared for 18 years off into the world, you know, will somebody continue to try to make things better, or do they just say, well, they've got Lennox-Gastaut and that's difficult and you've got bad seizures, so that's too bad, kind of thing, you know? So absolutely, it's something that they should think about. Will an MRI be helpful? It will be. If you're going to go to a callosotomy, they're going to have a new MRI to do it, but
Great.
It's not absolute to decide if you're a candidate necessarily right off.
Let's thank Dr. Perry.
Okay. Thank you all.
That was amazing. Thank you.
You bet.